The use of cryotherapy in the clinical setting.
Most commonly referred to as cold modality treatments. Cold modality treatments have a lot of benefit. They are very versatile and can be safely utilized throughout the healing process. Most commonly, cold modalities operate at a temperature of 32 degrees Fahrenheit to 65 degrees Fahrenheit. This translates to 0 degrees Celsius to 18 degrees Celsius. The term cold describes a relative temperature state characterized by a decreased molecular motion and the relative absence of heat. Cold applied to the skin will result in a heat transfer from the body or the skin tissue to the cold modality, usually resulting in melting. Cold cannot be transferred because the thermal energy always moves from a high energy concentration to a lower energy concentration. This transfer of heat will occur until the temperatures between the two objects have reached an equilibrium. The effects of cryotherapy are related to the slowing of cellular metabolism among the injured tissues. The body responds to the loss of heat with a series of local responses, including vasoconstriction, decreased metabolic rate, and decreased inflammation and decreased pain. The decreased cellular metabolism results in a decreased need for oxygen of the damaged tissues. Limiting secondary injury and neural inhibition are extremely important to the injury healing. During a 20-minute ice pack treatment, cellular metabolism is decreased by approximately 19%. Secondary injury is relatively slow developing. As has been described by several researchers, the maximum benefits of cold application in reducing secondary injury occurs when the cold treatment is initiated within the first 30 minutes following the trauma. Some of the physiological effects of cryotherapy. This is the decreased blood flow theory. The traditional theory for immediate care is that cold limits swelling by decreasing blood flow. The logic of this theory is as follows. Cold causes vasoconstriction, which decreases blood flow, and therefore decreases hemorrhaging, and therefore there is less swelling. Cold does decrease blood flow by vasoconstriction and decreased vascular permeability. Compression helps decrease underlying blood flow, and elevation reduces blood pressure. However, there are some pitfalls to this research. Cold is rarely applied sooner than 5 to 30 minutes post-injury. It takes time to remove the injured person, evaluate them, and come up with a treatment plan. Once cold has been applied, it takes an additional 5 to 30 minutes, depending on the depth of the injured tissue, to reach significant target tissue cooling. For most injuries, clotting occurs within a few minutes of the injury, thus hemorrhage ceases long before the blood vessels at the site of the injury are affected by vasoconstriction. Therefore, the benefits of cold on swelling cannot be attributed to decreased circulation. Despite the errors in the theory application, many individuals still buy into this theory of cryotherapy. More frequently among researchers, their theory is being replaced by the secondary injury theory. A second physiological effect of cryotherapy is decreased inflammation. The decreased secondary injury theory is an alternative theory that cryotherapy has little effect on hemorrhaging. Rather, current research suggests that cryotherapy limits the amount of secondary injury and edema. The logic of this theory is twofold. First, without cryotherapy, cells within the injured tissue that are not damaged during the primary injury suffer secondary metabolic injury because of inadequate blood flow and oxygen. Cryotherapy decreases the metabolic needs of these cells so they require less oxygen to function, effectively putting these cells into a state of temporary hibernation. Cells are therefore more resistant to an ischemic state caused by the compromised circulation as seen by the primary injury. The result is decreased secondary metabolic injury, so there is less total injury. This also means that there are less free proteins that are generated by phagocytosis and less edema develops. Secondary, damaged cells release chemical mediators which attack the tissues surrounding the uninjured cells, causing secondary enzymatic injury. Cold application suppresses the inflammatory response by reducing the release of inflammatory mediators, decreasing the prostaglandin synthesis, decreasing capillary permeability, decreasing leukocyte and endothelial interaction, and decreasing creatine kinase activity. This decreased secondary metabolic injury means that there are fewer damaged cells to release these chemicals. Cryotherapy has no effect on the primary traumatic injury. As has been said before, this cannot be prevented. Cryotherapy also has no effect on hemorrhaging that occurs prior to clotting. We can only limit the amount of secondary injury. However, we cannot totally eliminate secondary injury with the use of cryotherapy. Suppressing the release of inflammatory mediators decreases the amount of hemorrhage and swelling. Decreasing the mechanical pressure on nerves decreases pain. As muscle spasm and edema are reduced, the area is less congested, thus limiting the amount of secondary hypoxic cell death. Cold application decreases the rate that nerve impulses are transmitted and increases the depolarization threshold required to initiate the impulse. Changes in nerve depolarization and nerve conduction do not occur simultaneously because tissues cool at different rates. Superficial nerves are affected before deeper nerves. Decreasing nerve conduction velocity reduces the rate of synaptic transmission and increases the time required for the nerve to depolarize and repolarize. Cold application is useful in both primary and secondary pain control approaches. Pain is controlled via cryotherapy by removing chemical and mechanical pain triggers, reducing inflammation, and limiting swelling. Cryotherapy interrupts the nerve transmission and decreases nerve conduction velocity. Cold can inhibit pain transmission by acting as a counter-irritant, which triggers the descending pain control mechanism, resulting in enkephalon release. Cold also decreases lymphatic vessel diameter, but not as quickly as blood vessels. This is beneficial in that you can apply cold, perform some active exercises, and have a pain-free way of decreasing large proteins. Cryotherapy also decreases muscle spasm by suppressing the stretch reflex, by reducing the threshold of afferent nerve endings and decreasing the sensitivity of the muscle spindles. The use of cryotherapy decreases the nerve conduction velocity, thus breaking the pain spasm cycle, which decreases the speed of the reflex response and slows the spasm, and therefore the sympathetic nerve system stimulation decreases muscle tone through the reduced muscle spindle activity and gamma motor neuron potentials. The use of cryotherapy will result in a decreased ability to perform rapid movements and decreased overall strength in the muscles. Muscle tissues need adequate rewarming prior to intensive work or athletic type activities. This requires approximately 30 minutes for tissue rewarming to occur. The sensation of cold are experienced in phases. The acronym CBAN can be used to describe the sensations. It starts with the sensation of cold, followed by burning, then aching, and finally numbness. It takes approximately 20 minutes to achieve the final phase of numbness. For the thermal effects to be applied, numbness is the sensation that's required for treatment parameters. If an individual applies ice, determines it's too cold, and removes the ice and then reapplies the modality, the sensations of cold start over. Therefore, those individuals whom are sensitive to the cold treatment should be educated about the sensations in which they should be experiencing. For every modality, we need to understand the indications, precautions, and contraindications. An indication is a sign or symptom that indicates a certain intervention may be used. It could also be signs or symptoms that specifies a positive relationship for the use of that particular treatment. Indications for the use of cryotherapy include acute injury or inflammation, acute, subacute, or chronic pain, prevention of edema formation, prior to or with rehabilitation exercises, muscle spasm or spasticity, and neuralgia. A precaution is a measure taken in advance to prevent something dangerous or damaging. We need to be aware that there might be a reaction depending on the individual, and if an individual exhibits certain signs or symptoms, there may be a higher risk than someone who does not have those signs or symptoms. The precaution for the use of cryotherapy are avoiding large treatment areas if the patient has cardiac or respiratory issues, cold allergies or hypersensitivity to cold, previous experience with frostbite, or cold-induced neuropathy. A contraindication is a sign or symptom or a diagnosis which indicates that certain interventions may not be used. There is a negative association between the condition and the treatment techniques. The contraindications for the use of cryotherapy include compromised sensation, compromised circulation, uncovered open wounds, especially if we're reusing the cold pack, Raynaud's phenomenon, hemoglobinemia, deep vein thrombophlebitis or a DVT, and lupus. What about compartment syndrome? It's an acute injury. We can use ice for compartment syndrome, but we wouldn't want to wrap it on. We would not want to increase any pressure associated with the compartment syndrome. Raynaud's disease or Raynaud's phenomenon is an excessively reduced blood flow in response to cold or emotional stress. This causes discoloration of the fingers, toes, and occasionally other areas like the nose and ears. It is also sometimes called idiopathic vasospasm disorder. When the disorder's caused is idiopathic, it is referred to as Raynaud's disease, also called primary Raynaud's. If the syndrome is secondary to another disease, such as systemic sclerosis, scleroderma, or other connective tissue disorders, it is correctly referred to as Raynaud's phenomena or secondary Raynaud's. If Raynaud's phenomena is suspected to be secondary to systemic sclerosis, one tool which may help aid in the prediction of the systemic sclerosis is thermography. The pathophysiology of Raynaud's includes hyperactivation of the sympathetic nervous system, which causes extreme vasoconstriction of the peripheral blood vessels, which leads to tissue hypoxia. Chronic recurrent cases of Raynaud's phenomena can result in atrophy of the skin, subcutaneous tissues, and muscle. In rare cases, it can cause ulcerations and ischemic gangrene. The condition can cause pain within the affected extremities, discoloration or paleness, and the sensation of cold or numbness. This can often be distressing to those who are not diagnosed and sometimes can be obstructive. If someone with Raynaud's is placed into a cold climate, it could potentially become disastrous. There are some documented cases of occurrence of Raynaud's phenomena in only one extremity or one finger of the hand. When exposed to cold temperatures, the blood supply to the fingers or toes, and in some cases the nose or earlobes, is markedly reduced. The skin turns pale or white and is called pallor. It becomes cold and numb. When oxygen supply is depleted, the skin turns a blue color or cyanosis. These events are episodic, and when the episode subsides or the area is warmed, the blood flow returns and the skin color first turns red or rubor and then back to normal, often accompanied by swelling, tingling, and a painful pins and needles sensation. All three color changes are observed in classic Raynaud's. However, not all patients see the aforementioned color changes in all episodes, especially in milder cases of the conditions. Symptoms are sometimes thought to be due to reactive hyperemias of the areas deprived to blood flow. Another condition is frostbite or cold burn, which is on the right. It is a medical condition in which the localized damage is caused to skin and other tissues due to freezing. Frostbite is more likely to happen in body parts furthest from the heart and those with large exposed areas. The first initial stage of frostbite is sometimes called frostnip. At or below 0 degrees Celsius or 32 degrees Fahrenheit, blood vessels close to the skin start to constrict and blood is shunted away from the extremities via the action of glomerulus bodies. The same response may also be a result of exposure to high winds. The constriction helps to preserve the core body temperature. In extreme cold or when the body is exposed to cold for long periods, this protective strategy can reduce blood flow in some areas of the body to dangerously low levels. This lack of blood flow leads to the eventual freezing and death of skin tissues in the affected areas. Of the 4 degrees of frostbite, each has varying degrees of pain. First degree, this is initially called frostnip and only affects the surface of the skin, which is frozen. On the onset, itching and pain occur. Then the skin develops white, red, and yellow patches and becomes numb. The area affected by frostnip usually does not become permanently damaged, as it's only the skin's top layer that becomes affected. Long-term insensitivity to both heat and cold can sometimes occur after suffering from frostnip. Second degree, if freezing continues, the skin may freeze and harden, but the deep tissues are not affected and remain soft and normal. Second degree injuries usually blister 1 to 2 days after becoming frozen. The blisters may become hard and blackened, but they usually appear worse than they are. Most of the injuries heal within 1 month, but the area may become permanently insensitive to both heat and cold. Third and fourth degree frostbite. If the area freezes further, deep frostbite occurs. The muscles, tendons, blood vessels, and nerves all freeze. The skin is hard, feels waxy, and use of the area is temporarily lost, and in severe cases, permanently lost. Deep frostbite results in the areas of purplish blisters which turn black and are generally blood-filled. Nerve damage in the area can result in a loss of feeling. This extreme frostbite may result in fingers and toes being amputated if the area becomes gangrenous. If the frostbite has gone on untreated, they may actually just fall off. The extent of the damage done to the area by the freezing process of the frostbite may take several months to assess, and this often delays surgery to remove the dead tissue. Cold-induced neuropathy can occur when too much pressure is applied to an elastic wrap securing an ice pack over a large superficial nerve, resulting in overcooling of the nerve or neuropathy. Neuropathy causes the loss of sensory function, motor function, or both. Two common areas for cold-induced neuropathy are the ulnar nerve in the elbow and the common peroneal nerve, which is demonstrated in this picture. Again, it is okay to apply ice to these areas. You just may want to consider placing a paper towel between the ice and the skin or reducing the amount of pressure with which the ice is wrapped to the area. This chart is a demonstration of the tissue temperature cooling which occurs over time. After 30 minutes of time, there is a significant decrease in skin tissue temperature, even subcutaneous temperature, and a mild decrease in temperature of the muscle at 4 centimeters. Over a treatment time of 120 minutes, which is roughly 2 hours, we will see a plateau of the skin cooling and a relatively consistent temperature of the subcutaneous tissue, while there is still an associated continued decrease in muscle temperature. Therefore, to reach certain depths of target tissue, increasing the amount of treatment time may be required, although the associated risks associated with prolonged cryotherapy exposure increase with the length of the treatment as well. The thickness of the patient's adipose tissue layer can be calculated by determining the skin fold overlaying the treatment area and then dividing that number by 2, which is skin fold divided by 2. Thick insulating layers of adipose tissue reduce the rate and depth of intramuscular cooling and require longer treatment durations to reach therapeutic treatment temperatures. With less than 8 millimeters of subcutaneous adipose tissue, intramuscular cooling occurs at a rate of 1.3 degrees Fahrenheit per minute per 1 centimeter within the muscle. At 10 millimeters and 18 millimeters of adipose tissue, the rate of cooling decreases to 0.81 degrees per minute. As can be seen in the study above, a 25-minute treatment may be adequate for a patient with a skin fold of 20 millimeters of fat or less. However, a 40-minute application is required to produce similar results in a patient with skin folds between 21 and 30 millimeters, whereas a 60-minute application is required for patients with skin folds of 31 to 40 millimeters. The data from this study suggests that adipose thickness does have indeed a strong influence on cooling. Across all groups, cooling time increased rather dramatically as skin fold thickness increased. Although a 20-minute treatment will produce a typical effect in patients with skin folds of less than 20 millimeters, patients with skin folds between 20 and 30 millimeters will take twice as long, nearly 38 minutes, and patients with the skin folds in the 30 to 40 millimeter range require 3 times as long, an almost unheard of 59-minute treatment to produce the very same temperature effect. Based on this study's findings, they offer Table 1 as a clinical recommendation for cryotherapy duration required to produce a typical cooling effect. Note that the researchers of this article are not implying that this effect is optimal. Optimal cooling has yet to be adequately identified. Therefore, it's apparent that the amount of adipose tissue is highly dependent on the effects of the superficial treatment, especially in those of cryotherapy. Tissue cooling and warming is dependent on several factors. Number 1, the temperature gradient. The more difference between the two temperatures, the more rapid and deeper the energy exchange. The duration of the treatment, the longer the treatment, the greater the depth of the treatment. Adding compression can also enhance the effects of treatment. The adipose layer acts as an insulator. Maximum analgesia has been demonstrated to occur at 58 degrees Fahrenheit. Tissue damage may occur below 55 degrees Fahrenheit. You also have to consider whether or not your patient will be sedentary after the ice. If they are, then the effects can last for 1 to 2 hours. If they're active after the ice, it increases muscular warming. A little less than 15 minutes of exercise will rewarm the tissue. So this begs the question, should we wrap an ice bag on an athlete and send them to class? When this happens, we can't watch them to determine the effects of ice, and the amount of exercise required to walk to the next class may negate the effects of cryotherapy at all.